Welcome to the CI Rescued program. It's a nursing competency improvement to reduce emergency department admissions, particularly in the long-term care environment. My name is Mark Jones, BSN, in the FNP program at Roberts Wesleyan University. The purpose of this CI was to address the shortfall that we discovered during the COVID pandemic at the long-term care facility at the VA facility in upstate New York. It was determined that the facility had allowed some of the typical nursing skill sets to atrophy because they had ancillary services available, such as laboratory services. And in the middle of the COVID pandemic, they were denied access to those ancillary services. So we determined that we needed a two-part corrective action to prevent suffering and harm to the patients. The first part was to improve the skill set of identifying correctable illnesses that were resulting in unnecessary ED admissions. And the second part was to work on the competency skill set regarding typical nursing skills such as blood draws, IV administration that came up during the pandemic so that we could treat patients in the long-term care facility and not have to admit them to the ED. The case study I chose for this project involved a 72-year-old male patient that presented on the unit with altered level of consciousness, but no other significant change in his vital signs. The altered level of consciousness persisted for 2 days. The nurse practitioner was notified. The assessment was that there was some sort of infectious process going on, and they ordered lab work to determine which bacteria was probably likely causing the problem so that they could treat it effectively. But due to the lab services not being available and the nursing skill set not being present, they were unable to get cultures to determine what bacterial form was present, and they only had the ability to treat the patient with IM Recefin, which turned out to be the wrong antibiotic for the microbe that was involved. The patient continued to decline and ended up with an emergency admission, an extended stay in the ED, and because the long-term care population has some vulnerabilities to ED admissions, skin breakdown, delirium, it was a very prolonged stay in the ED. The clinical problem, significance, and clinical setting is that the timely identification of illness in LTC is critical to preventing them going into the hospital. Early interventions are limited to what the nursing skill set can accomplish. So in this case, we've determined that when the nursing skill set wasn't there, they delayed 2 days in identifying the problem to the nurse practitioner to begin with. And then once the nurse practitioner was engaged, they lacked the skill set to identify the microbe so that the nurse practitioner could give the appropriate antibiotic. The cost, both in pain and suffering to the patient and financial cost to admission to the ED, is significant. The clinical setting for this CI is a Veterans Hospital LTC facility in upstate New York. Thank you. The population health perspective, ethnically largely Caucasian, with a fair amount of African American presence, but very little Latino or Asian population. It's the nature of upstate New York's veteran population. There were 2 females that were in the LTC at the time of the study, so there was some gender variance. High school education was the most common education background for this group. Military experience, the majority of the veterans that were still in the facility were Vietnam War. We did have Korean War and Gulf War veterans as well. The PCAT question for the CI was that population was long-term care residents at a VA facility at risk of deterioration, hospitalization due to failure to rescue. The intervention being proposed was evidence-based implementation of a peer mentoring and skill champion program to assist the LTC staff to master and sustain clinical competencies, both in the diagnostic of problems in the LTC community and the skill set to correct it. The current practice, the facility had a very limited educational component. They did have 4 master's degree nurse educators, but they focused on required learning that came down from a federal level and did not have much tailoring involved. As far as the skill sets that were supported by ancillary services like blood draws and IV services, they did not require anything other than 3 needle sticks at time of hire, and they required no refreshing up into 10 years employed for the longest nurse that was on the service. The outcomes we're looking for is patient-centered outcomes. We hope to reduce the admissions to the hospital from LTC for treatable conditions, reduce the morbidity, mortality, and failure to rescue of the patient population. Staff outcomes, we want to improve the feeling of support experienced by the staff personnel, that they have the skill sets to intervene to help patients, and we want to increase their skills so that they can perform the critical nursing skills diagnostically to determine that somebody is ill using more advanced techniques, and the blood draw and IV administration techniques that are required. Second year of COVID, they were expected to do IV drips, which hadn't been done at the LTC in 5 years. Time frame after during the study is 6 months to 1 year. The literature review focused on 2 main areas: prevention of ED admission from long-term care or skilled nursing facility, and evidence-based strategies for peer support and nursing competency. The research on prevention of admission from long-term care facility had a lot of research that was done from the hospital side. I found a limited number that had the perspective from the nurse long-term care facility side, because they were focusing on EDs not wanting the patients coming in. But it was the same perspective, just the mirror image of the rationale. The key phrases that we used were, failure to recognize patient condition, failure to communicate and change a patient condition, clinical decision making poor or lacking, inability to perform particular skills. We did the standard research, CINAHL, Cochrane, UpToDate, and they were selected as initial databases. I alternated using long-term care, nursing home, skilled nursing facility, because depending on which country and which research organization was running the research, they used those terms interchangeably. I did have some delimiters that I could have limited. If I had too many results, we could have added, veteran into the mix to limit it to veterans, but the literature review did not have a problem. We had a sufficient number of hits without being overwhelming. The body of evidence was heavily weighted in level 4 and level 5 research in both cases. There was a single level 1 research study on peer support nursing competencies that talked about preceptors and the effect that they had on improving skill sets. That was double-blind research. But there were a number of studies in both research themes that met the criteria for the research. I chose the INTERACT model for the basis for the CI. INTERACT is a model that talks about the process and the flow of evaluating patients that deteriorate to figure out at what point we can act more speedily and have clinical paths identified to result in better outcome for patients. INTERACT has 5 key components. Principles of quality improvement is all about root cause determination, using benchmarks to figure out what reason is behind the failure in the analysis, to figure out what the actual cause is so that you can direct corrective action at the cause. They focus on early identification, evaluation of changes in condition, which is exactly what our process for the first part of this is. We need to figure out why patients are ending up in critical condition when there was actions that could have been taken at an earlier point to stabilize them, preventing ED admission. The next part is management and common changes in condition, which is what we're talking about with competency skills. We want to implement an appropriate treatment and competency skill improvement program that increases the ability of the nursing staff to not only assist in the diagnosis of the problem, but actually have the skill sets to do the appropriate interventions to prevent the admission. Improve advanced care planning is the fourth leg of Interact EBP. You have to figure out in advance what their wishes are and determine that the care is appropriate to their wishes. It is a common strain these days that there are a large number of limitations as to what people want. It used to be DNR, DNI. Now it's DNR, DNI. I do not want artificial nutrition. I want a trial of CPAP. A lot of conditions that are people want to delineate ahead of time needs to be built into their care plan and figure out that we're meeting that goal. And then improve communication and documentation, because communicating what's going on between practitioners, many of which that were not on site, and the nursing staff is critical. The communication that needs to occur between the nursing supervision staff that's on the facility and the floor staff that have different access to different skill sets and technologies is critical. Reaching out to the providers, both the mid-levels and the MDs that are on call to determine the appropriate treatment path that they want to take, and keeping them in the loop if we run into a problem where we can't make one happen, like the times they can't get blood to determine what the illness is. So my proposed CI process is 4 phases. Following project approval, we select champions. Working with the management staff, nursing demonstrate their competencies. There is some discussion about providing incentives through evaluation bullets based on becoming selected as a champion that results in future promotion. Once the champions are selected, they go to phase 2. They do some more intensive education with the training department. More specifically, not the skill set because they were selected for that to begin with, but more the process of documenting what they mentored and how their students were being mentored, and a documentation about how they're going to be graded on their performance. Phase 3 is the bedside. It's the operational element. They go and they support the nursing staff at the bedside, helping them diagnose problems, helping them perform skill sets that they've got rusty skills with, or mentoring new nurses that have never done it before. And phase 4 is the program manager. He looks at the evaluations by the people being mentored. We look at the evaluations and responses by the staff. We look at the results from the MDS team and the informatics people on how often people had admitted, and we determine if we have a reduction in patient decline and hospital admission. So the improvement CI is Greg's story. Greg was a similar story to the beginning story, except for the nursing staff notified a practice champion that had them come and help them assess. Their assessment skills were higher to begin with because we work with education to improve their skill set prior to that. But between the floor staff with improved heightened awareness and the practice champion that came, Greg gets evaluated and determined to be in trouble much sooner. They notify the practitioner, mid-level on duty, orders the appropriate labs. We get the labs. They determine that it's not just an ESBL type infection that can be treated with a different antibiotic, but he also has a significant electrolyte problem that's out of balance. So we're able to do PO supplementation and PO antibiotics. They avoid the IM injections of the wrong antibiotic as in the first case, and he stays in the facility. Greg, it turns out, had not just an infection, but he also had an electrolyte imbalance, which was easily correctable. The nurse practitioner was able to order the right antibiotic and electrolyte balancing, and Greg got to stay in the facility where he and his family wanted him to stay and not have to be admitted to the ED. So I had a stakeholder meeting with the powers that be at the VA facility in the director's office. All of this fell underneath the auspices of the chief nursing officer. The chief nursing officer at the VA owns the training department, and they own the long-term care facility department, and they own all the players that are involved except for informatics. So the meeting was held. The discussion about cost and implementation, they were quite pleasantly surprised about the lack of cost, although they also pointed out things like the VA had a print shop service that I was unaware of that could make providing the materials cheaper. And the unit managers wanted to step up to the plate and say that they could take the time to do the time on the floor to allow people to attend the training without having to pull additional staff in for overtime. The cost of the project was actually pretty minor overall. Personnel, it was not going to require a lot of time for anybody other than the manager. The training, the VA already allocates a certain number of hours to training every quarter. So it would be just an issue of prioritizing this in the training department schedule and budget to work that in. The cost of supplies, once again, they brought up the fact that we probably could use VA print services to reduce that service. The training requirement, if they were unable to cover the floor, and that's always a question. When I originally budgeted this, I didn't plan on the managers completely picking it up, so I covered the cost of paying somebody else to cover the unit for them while they were gone. It worked out to a total of about $4,700 to implement it at our facility. The return on the investment, however, is pretty significant because there's 2 points to this. The pain and suffering for the patient doesn't have a real price tag number attached to it. Allowing a veteran to be painfully poked and prodded for unsuccessful treatment, allowing their condition to deteriorate to the point where they have to have an emergent transport to the emergency department and put them into a situation where they're in a noisy, non-pressure relieving mattress, ED environment. That's just pain and suffering for the veteran. But the Keesler Foundation in 2020 did an average cost for hospital stay in New York, and they determined that the cost per stay, which the VA does pay for when veterans go to the hospital, is $36.76 per day, and that the result of a pressure injury, even a stage 1, can result in an additional $800 to $893 dollars in cost for care and treatment for the stage 1. If it advances to stage 2, the cost of treatment for that is estimated at $3,560 by Padula. If they go to the ED for more than 2 days, the numbers are pretty high. The steps for project approval are pretty clear. Written proposal goes to the chief nursing officer through their long-term care associate chief. It gets circulated amongst the other associate chiefs, and then the chief nursing officer has final approval. The evaluation of the plan is pretty easy. The informatics people actually already collect data on how often people go to the hospital, and we have an MDS coordinator staff that do assessments on patients when they return to the facility from any trip off the facility, whether it's to a specialty care or an ED visit, to determine if there's any change in patient condition or any other significant change in their life or functioning ability. My personal reflection on the process was that in the very beginning, the process of doing nursing research was a lot more complicated. I didn't realize that there were quite so many research gaps until you tried to focus the problem down on a focus PCOT question. The cost elements of this and the design elements for the CI, finding an example template was interesting. I wasn't aware that there were quite so many models out there. And then just the role of nursing, nurse management, and NPs being an advocate for your program is more complicated than I thought it was.